Good afternoon to everybody, and a warm welcome to this Ifso-Ec and Young Ifso joint webinar. My name is Paulina Salminen, and I have the pleasure of welcoming you here. I'm a professor of surgery and a bariatric surgeon scientist at University of Turku and Turku University Hospital in Finland. I'm also actively involved in Ifso, and I'm the current president-elect for the Ifso European chapter and the PI of the Finnish Sleeve Pass trial. It is my great pleasure to introduce our distinguished invited speaker, Professor Jane Blaseby, who is a professor of surgery at the University of Bristol and an honorary consultant surgeon at University Hospital Bristol and Western NHS Foundation Trust UK. Jane has a long-standing interest in evidence-based surgical practice and patient-centered care, leading a team of academic surgeons and methodologists. She enjoys developing methodological innovations to optimize surgical trial design and conduct. Currently, she is the PI of the BiBand sleeve study, which is a multi-center randomized clinical trial comparing the clinical and cost effectiveness of gastric bypass, gastric band, and sleeve gastrectomy. Interestingly, she's not a bariatric surgeon, she's an upper GI surgeon, but we're very grateful for her scientific contribution in the field of metabolic bariatric surgery. Jane leads the Royal College of Surgeons Trial Center in Bristol and co-directs the Surgical and Orthopedic Innovation Team in the Bristol Biomedical Research Center. Ultimately, she hopes to see NHS surgical practice become evidence-based in her lifetime, and I personally really share this wish and hope this evidence-based surgical treatment expands globally. Then we have our expert panelist. So Moritz Felsenreich from Vienna, Austria, who's the president of elect of Young IFSO and the executive director of the IFSO European chapter. He now works as the attending bariatric surgeon at Vienna Medical University. Recently, he became a professor at Vienna Medical University after finalizing his PhD already in 2018. For our other panelists, we have Professor Torsten Olbers from Linköping University, Sweden. He has been the principal investigator of several randomized clinical trials within metabolic bariatric surgery, and he's currently leading the Scandinavian large BEST study, which is bypass equipoise sleep trial project, and he's also the principal investigator for a Swedish national program for adolescents undergoing bariatric surgery, the AMOS trials. He was also involved in the Swedish obese subjects SOS study. He has described and refined widely unused standard omega loop technique for laparoscopic gastric bypass together with Professor Hans Lönnroth. Last but not least, I would like to present my co-moderator, Wai Yang, who is the current president of the Young IFSO and works at the first affiliated hospital of Jinan University, Guangzhou, China. He's also the vice president of Jinan University Institute of Obesity and Metabolic Disorders and the director of Chinese Obesity and Metabolic Surgery Collaborative and Database. I'm very happy that we are apparently quite a large crowd to listen to this interesting webinar. And to start off, as we have a lot of sleeve versus bypass RCT PIs here, and for the audience, we actually would like to start off with a poll by asking you, what is your estimate? What will happen to sleeve gastrectomy rates in the next 5 to 10 years? You have 5 different options to choose from, so please start voting, and it's going to be interesting to see whether our presentation then changes your views. So now we have the time to vote. So the 5 options: increased use, it remains the same; reduced interest, but still commonly used; very reduced interest, or only for special cases. So this is for sleeve gastrectomy next 5 to 10 years. It is very difficult to predict the future, but this is what we're actually asking for your opinion. And Stephanie, can you please tell me whether when we have the poll at this point? Thank you very much. So this is where we start off for the webinar. So the most common is that it's reduced interest, but still commonly used. So 47% for that. It remains the same, the most used technique, 22, 18% for increased use, and only a few people, 7 altogether, for reduced interest or only for special cases. So this is very interesting. And now I will pass on the torch to Professor Jane Blaseby. So please, we would be delighted to hear the talk. So we will have the recorded talk. Thank you very much.
Good afternoon. It's a pleasure to talk to you today about the bi-band sleeve results. Now, I don't have any financial conflicts of interest, but I think it's important to explain that I'm not a bariatric surgeon. I've never seen or performed any bariatric surgery. Once upon a time, I was an esophageal cancer surgeon. I think that means I may be impartial, but it also means I come with a certain amount of ignorance, which is, again, may be beneficial. We'll see. Okay, so this story started over 10 years ago, back in 2009. I was talking to Richard Welburn, and we were talking about the differences in practice in the local area around Bristol in the UK, where his practice was predominantly gastric bypass, and another local hospital, the practice was predominantly gastric band. And then we looked at the data, and you can see very clearly the split in practice. It's a long time ago, but this was relevant then. And the evidence for the two procedures was summarised in that systematic review published in 2009. And although it included 20 trials, there were just 2 that compared the 2 commonest procedures head to head, gastric bypass versus gastric band. They were small studies. They were not performed in the UK, and the reviews, there was a Cochrane review as well, concluded that well-designed and conducted randomised controlled trials were needed, but they said they would not be possible because of surgeon and patient preferences. Now, things like that in Bristol are a red rag to a bull. We love difficult trials. So we put in a grant application for the bi-band study. It was funded. We hoped we would randomise over 700 patients. We were told we were mad when I talked to the BOMS meeting in Bristol that year. And in Taunton, in Richard's Centre, and in Southampton, that was Jim Burns' centre, they were up for it. They were up for being supported and taught how to randomise patients, how to then explain the clinical equipoise between band and bypass. Very important to learn to balance the procedures and tell patients we don't know what's best, so we need you to enter this research study. And together with their teams, they were successful. The traffic lights went green, the pilot phase was successful, and we demonstrated to ourselves, to the country and to our funders that it would be possible to recruit. We expanded bi-band into 6 more UK centres. And then the next hurdle came along. When one is running randomised trials, there is hurdle after hurdle after brick wall after hurdle. And this one was really interesting, sleeve gastrectomy. As you know, sleeve gastrectomy grew in popularity and in practice. In fact, it spread like wildfire across the world and the country. And by 2015, or about the middle of that decade, it was the second commonest operation to gastric bypass, and gastric band was losing popularity. There was a literature review as well, and the same literature review said, the updated Cochrane one said, we still need evidence. And there's this sense of, is new better? Because everyone thought it was, and that's how practice changed. So what we did was we reapplied for more funding. We adapted bi-band to a 3-group trial to become bi-band sleeve. We increased our sample size to do that. What was impossible at 700 became even more challenging at 1300. We maintained the same primary endpoint, a dual endpoint of weight loss and quality of life. We hypothesized that there would be no difference in weight loss between the 3 groups, a non-inferiority hypothesis, but we also hypothesized, based on the optimism bias around sleeve, that sleeve would be superior to gastric bypass and gastric band in terms of quality of life, and that bypass would be superior to band in terms of quality of life. We then expanded further to 12 UK centres, and they're shown here, and they were amazing. We'll come back to say thank you to them later on. And with support, with education and training and encouragement to continue to create an evidence base, we managed to recruit 1,300 patients. We decided to keep band in because even though there was a sense, as we all know, that it was not as good as the other procedures, there was no hard evidence to demonstrate that. And we decided, with our safety committees overseeing the study, we could continue to safely recruit in order to create that evidence to inform health policy and decision making. So how did we get on? During that period of recruitment, nearly 7,000 patients were screened for trial eligibility, of which 68% were eligible, meaning the results of biband sleeve will be generalisable to the UK population. The 3 groups were randomised, there was a wait of 5 months to surgery, and 88% underwent some sort of surgery. And there was a 9.7% group of patients that did not receive their randomised allocation. They crossed over after randomisation. That number's small, acceptable for a surgical trial. You'd worry if it was 20%, it would mess up the data, but 9% is acceptable. And our primary endpoint, data completeness, was acceptable. I always wanted it to be better, but we had 80% of participants with their weight and 74% of participants with their quality of life questionnaires completed. A large-scale pragmatic trial. Now, it won't surprise you to know that the baseline characteristics of those 3 groups of patients were similar. We published the baseline data earlier in the year, and they were not only similar, they were similar to each other, and they were similar to that of the UK population undergoing bariatric surgery, as evidenced in our National Bariatric Registry. We had more women than men. The mean age was 47. The mean BMI was 46, so these patients were heavier than their European counterparts. And you can see that a third of them were diabetic in all 3 groups. The primary endpoints was a co-one hypothesised around weight loss and quality of life. We measured multiple secondary endpoints. These included different metric for weight loss. We measured total weight loss. We measured other aspects of quality of life. We measured a lot of blood data to try and capture the comorbidity resolution, although we didn't be able to get the strict measurements for everything, but we've got good information. There were safety details recorded extensively and a health economic in-depth analysis. We made comparisons in the data between the groups, so between bypass and band, between sleeve and bypass, between sleeve and band. And we compared those differences, and I'll show you the mean differences on the whole and the confidence intervals. The baseline in this study is time of randomisation, and wherever, unless I mention it, wherever I show you data, the comparisons are analysed in an intention to treat analysis, an ITT analysis, which is trial speak for we keep everyone that's randomised in the analysis. The reason why we do that is because at baseline, when they're randomised, the groups have similar characteristics, and that's the power of a randomised trial, that you have groups with the same known and unknown characteristics. So when you look at the differences between groups, you're looking at the differences because of the intervention, not because of baseline different variables. Now, we did some sensitivity analysis. That means that we stress tested the findings. And we stress tested them by removing specific groups of patients and then analysing the remaining ones. We excluded people with missing data at 3 years, people who didn't complete their follow-up, those who didn't undergo surgery, those who crossed over and didn't receive their allocated surgery. And we grouped the patients by the surgery they received rather than by the surgery that they were allocated to. And we analysed the primary outcomes. So you're looking, in a sensitivity analysis, you're looking to see if by cutting the data in different ways, it changes the findings. And of course, you don't want that to happen, but it sort of stress tests the data. And we did subgroup analysis by participants with or without diabetes at baseline and by participants within 3 different BMI categories at baseline. Again, to see if we could identify subgroups of patients that may or may not benefit from the different procedures. Okay, so to some results. Weight loss. This is the Headline, in many ways, an incredibly important finding. So I'm going to show you a little table that shows you the proportion of patients in each group that have lost 50% of their excess weight by 3 years. So bypass, band and sleeve, the proportion that have lost 50% of their excess weight. And before I show it to you, I will tell you I was staggered to see these results. I did not see this coming. There is a huge difference between the three groups. So bypass, 3 years after surgery, 2/3 of those patients had lost 50% of their excess weight. For band, it was a quarter, and for sleeve, it was 40%. Now, we pre-agreed, we hypothesised that a clinically important difference in weight loss between those groups would be more than 12%, a proportion of more than 12%. You can see those groups are way more than 12%, all three of them. That was our non-inferiority margin. We pre-agreed that. And when you tabulate that, the difference in proportions between bypass and band is 41%, with the confidence intervals going as high as 48%. Between sleeve and band, it's 15%. But the most important finding, I think, is these differences that we see in this study between sleeve gastrectomy and gastric bypass. So the confidence intervals range from 34 to 18. So sleeve gastrectomy could have been as much as 34% less good at the weight loss than gastric bypass, with an average difference in proportions of -26. When we try and put that onto a table to help explain it further, you can see the non-inferiority margin at 12, -12, which means that on the screen left, things are inferior, in the middle they're non-inferior, and on the right they're superior. We can see that bypass is superior and non-inferior to band, as is sleeve gastrectomy. No surprise, I appreciate that. But the important finding is that sleeve gastrectomy is inferior to gastric bypass in terms of weight loss at 3 years. So when we stress test those findings in those other groups where we remove particular participants, the headline finding is that the main findings of the study hold within the other sensitivity analyses. And that's, as a trial, is what you want to see. It becomes difficult to start interpreting data if you get different results between the primary analysis and the sensitivity analyses. But in band sleeve, we have not found those things. We have consistent findings across the groups. If anything, you have a more pronounced differences between the proportion of excess weight loss between the three groups, shown here. When we exclude patients with missing data at 3 years, you get 77, 21, 44, for example. We look at the bottom group when we analyse the patients by the group, by the operation which they actually had rather than that to which they were allocated. Again, you get more pronounced differences between the three groups. So these are reassuring data to underline the headline findings. In the subgroup analysis, do we see difference between patients with diabetes at baseline or not? 1/3 of the patients were diabetic. The answer was no. They were similar. P was 0.77. The effects were similar whether they're diabetics or not. And the same was true for whether participants were in these 3 different baseline BMI categories. There was no difference between the groups. So if we change the metric and put that into TWL, which is make it easier for meta-analysis and for joining data with other trials, of course we see the same pattern, but importantly you can see here that at baseline patients were in each group about 130 kilograms. In bypass they lost about 35 kilograms, in band 18, and in sleeve 25 kilograms. And the mean percentage change from baseline is also shown there, 26 and 14 and 20. And that's interesting because all 3 of them are more than 10%, which is the maximum that would be achieved from the new pharmaceutical agents. So all 3 surgical procedures do lead to significant weight loss. This just plots that graph, which may be useful to use in clinical practice in the future to show patients, to help them make their choice. In my mind, it's a very clear picture. And when we put the stats around that, we see significant differences between the TWL in the three groups, not surprising, with sleeve and bypass being better than band, and bypass reducing weight more than sleeve significantly. Okay, so now we come on to the co-primary endpoint of the EQ5D, quality of life. What we find with these secondary endpoints is, on the whole, they're mirroring the weight loss pattern. So we have high score equal better quality of life here. So gastric bypass is superior to sleeve, which is superior to band. And a minimal important clinical difference in the EQ5D is 0.03. And you can see that those mean differences were different between those compared with band, but not quite different between sleeve and bypass. We stress test the EQ5D data by removing people from the subgroups, and the findings remain. So reassuring findings, nothing changes from the headline primary intention to treat analysis. The subgroup analysis for the EQ5D with and without diabetes, no difference. For the different BMI categories at baseline, no difference across the three groups. And then we move into some selected quality of life domains. I can't show you all of them. We measured 30 odd different aspects of quality of life, but the ones I'm going to show you now are those that were selected by our trial steering committee and by our patient advisory group. These questionnaires were very well validated and widely used in healthcare and in obesity surgery. So for the SF12 physical component scale, you can see that gastric bypass leads to better physical function than sleeve gastrectomy. Both are superior clinically and statistically to gastric band. The patients wanted us to specifically use the impact of weight on quality of life score, and this is the overall score, which has a minimal important clinical difference of between 7 and 12. You can see that's reached in the band comparisons, but not in the sleeve and bypass comparison, although that was statistically significant. And when we look at the gastrointestinal symptoms using the Gigli quality of life measure, which really does encompass reflux symptoms well, we can see no difference between the groups statistically, but perhaps importantly, no difference between the bypass and the sleeve group in terms of GI symptoms, including reflux disease. In the IW-QoL Lite, there's a scale that measures self-esteem that the patients wanted us to examine, and interestingly, huge differences between the three groups, all of which were important and significant, with bypass leading to better self-esteem again. And then the patients wanted us to report sexual life measured in the IW-QoL Lite, and both bypass and sleeve lead to better sexual functioning than band. No difference between sleeve and bypass. It really new data, this, and to inform patients to make decisions in the future about their choices of intervention. So some resolution of comorbidities and some thoughts about why that is and maybe their response to supplementation. The HbA1c shown over time for the three groups, with the lowest score being in bypass, which is significantly better for bypass versus band and sleeve versus band. And I've plotted here, or it's been plotted for me, the proportions of patients in each group with HbAc less than 48 millimoles per mole. And this is a key data, and it shows that at 3 years, at 36 months, over 80% of patients have reached that figure, which is excellent. And again, all three groups would be better than that achieved by pharmaceutical interventions. So some data on lipids. So you can see the HDL-C and mean triglycerides here. The patterns are the same, again, all following the weight loss trajectories. Vitamin D and bone health are reassuring. We can see patients were taking their supplements. We don't see any clinically worrying data here. And to just show you the final chart like this is the ferritin, folate, serum iron and vitamin B12, again within normal ranges and the difference representing the supplementation being taken by the bypass and sleeve patients. Okay, safety. So it's all very well seeing how effective these procedures are, but it's essential we're aware of the safety data, because this may well change the implementation of the results and the implications for everything. This has been grouped by counting all events between surgery and the first 30 days, and then between 30 days up to 3 years post-randomization. I'll also present the individual deaths by group and cause of death, and finally some selected surgical complications that I know are of interest. So when we look at total events in the first 30 days, band has the lowest number of total events, meaning it's sort of the safest at that stage. Those were not found to be important statistically. When we look at the total number up to 3 years, sleeve has the lowest number of total events. And there were significant differences between the number of events associated with sleeve gastrectomy compared with those with band and also with bypass. So sleeve has got fewer events. Death by group is similar across all 3 groups. These are just deaths that you would expect in this type of cohort of patients. Not all of them had actually undergone surgery that died. There was one, what you might call technical death in the band group, in fact, from peritonitis due to a leak from band sutures just after 30 days. But these are not dissimilar to registry data. And then this table shows the selected complications by procedure, particular surgical complications. And I think on the whole, they're showing the safety of the 3 procedures. So 15 patients randomised to bypass required surgery for an internal hernia, of which 4 required a small bowel resection. There were 4 episodes of needing redo surgery for an anastomotic problem listed here and the different time points. 3 patients out of 434 in the sleeve group had a sleeve fistula and its serious complications. And then there's the corrective surgery reported in the middle there for gastric band. So relevant to the UK, we have done a cost effectiveness analysis led by the team from Oxford. And this has used all data for patients up to 3 years post-randomisation in and outpatient care, A&E visits, all medication analysis, intervention analysis, and the perspective is definitely that of one of the NHS. First thing that is done is a QALY is calculated, which combines a measure of quality of life, the EQ5D, with time, and we can see that gastric bypass produces the most number of QALYs, just over 2, compared to lower ones for sleeve and band. That's important. And now what's the cost of that QALY? Well, if you look at the cost without the intervention, you can see the costs around band are more than those needed for sleeve and bypass. But when we add the cost of the primary surgery in, bypass is the most expensive, followed by sleeve, followed by gastric band. And then what happens is that the QALYs are combined with the costs to produce an incremental net monetary benefit, and that is looked at by a willingness to pay per QALY, shown on the x-axis. So at the 20,000 cut-off and at the £30,000 cut-off, which are what the UK NICE would be willing to pay for a QALY, in that category there where the dotted vertical columns are, you can see that in blue we have bypass being the most beneficial over sleeve, and both are markedly beneficial over gastric band. And when we look at how likely that is to be true, because there's always a certain amount of estimation that goes on with all cost effectiveness analysis, the probability that the most cost effective intervention is actually the best intervention is shown here. And there's no doubt about it. Gastric bypass in blue has a very high probability of being the most cost effective option at the 20 and 30,000 thresholds that are used for QALYs, the purchase of QALYs, if you like, in the UK. Line findings here to summarise. Gastric bypass, we have found in the Byband sleeve study, is more clinically and cost effective than sleeve gastrectomy and than gastric band. I know that is not of news to you, and sleeve is also better than gastric band. Based on the cost analysis, we would say that choosing gastric bands would have harms at a population level because of the opportunity cost in investing in bands would prevent patients from having the safer and the more effective other procedures. So what does it mean? And I've put my Barbie photo here because if you haven't been to see the film, I would recommend it. If you go and see Barbie, it makes you think. It really makes you think. I've seen it twice and I thought more the second time than the first. And so what do the results of Byband sleeve make me, or make us, make you think? Because that is the key. What do we do now with this data? We don't just publish it. We need to actually think, how can we use this information to change things for better for patients, for us, for surgeons, and for healthcare providers? And my first comment, I think, is that trial participation matters. So it's almost an ontological explanation, is that the teams I've worked with over the last 12 years, I have seen grow in knowledge and grow in understanding and change their practice because they're beginning to be able to really appreciate what evidence is and the relevance of thinking about evidence and other people's practice in the context of their own as they experience randomization and follow-up. I think that participation in trials means that surgeons think more, we question our practice, we learn and we change our practice as we take that all in. And to me, Byband sleeve is an example of how the bariatric surgeons across the country and their teams have moved to that higher level. And that has implications for what they will do next and how they are and the surgery they offer and how they talk to patients. And that's incredibly important. Of course, it also means that in the UK, we've demonstrated we can do this. We can build evidence together. And if we did it again, we'd do it faster and better. And the thing we need to do is identify the next most important research question. Really keen to hear views from you on that, or email correspondence, or we can have meetings, because I can facilitate this. I don't want to lead it anymore, but I've had a lot of experience now and learnt the hard way, so I'd want to share that with other people. Maybe two questions of importance here. One is the single anastomosis gastric bypass versus Roux-en-Y. Is that worth doing? Probably is. But to me, the most important question is the latter one. We really need to compare surgery with optimal medical management and follow patients up well and really work out how we can help people best and the most cost-effective way. And I think we are well equipped to do that. There's a couple of studies that may start or are running at the moment that are looking at it in different ways and in small groups of patients, but there may still be the need to really tackle this head on across the board and answer that question. Next thing I think that Byband sleeve has taught me is that when one is introducing a new procedure, it needs to be done carefully, and that therefore there's an opportunity for risk management. How can we mitigate complications, side effects that inevitably occur during innovation? And sleeve gastrectomy came in without evaluation alongside Byband sleeve, and I think that could have been done better. And we need to be really thoughtful about how we introduce new procedures. I've listed a few there, but patient consent, transparency, early sharing of data will inform decisions around them, and it may mean that new procedures that aren't more effective than existing ones will be curtailed sooner than ones that are just allowed to run wildfire. So we are tending to try and get some funding with Karen Coleman and Marianne Holliman to get some grant funding to follow up our cohort in Byband sleeve to see what the long-term data show. It's really important that we do that. And just to finish by saying, I am so indebted, we are so indebted to all the participants in this trial, all those patients that were prepared to be randomised filled in questionnaires came back for assessments. We're so indebted to them. And to the trial executive group, Chris Rogers, Graziella Mazza, Eleanor, the three key people in our trials team. At the trials unit, we have a trial management group shown here who've met twice yearly for 12 years. Some extra people from our centre in Bristol, Natalie, Karen and Katie, have done various things along the way. And we've had independent oversight by an international committee, data monitoring committee and trial steering committee that have met annually, and given us huge amount of advice and support, without which this trial wouldn't have been possible. We have also had huge, we're so grateful to all the surgeons, nurses and dietitians that have worked so hard in this study. And their logos are shown here, and I'll be pleased to answer any questions or do contact me following the end of this seminar. Thank you for listening.
Thank you so much, Jane, for your excellent presentation and interesting results. And I will soon give the floor to our panelists, but I perhaps would like to start off by asking a very quick question, which I think is underlying the idea, because as PIs, I think we all share your vision on having hurdles after hurdles and brick walls after brick walls, but still defining the primary endpoint and the trial design is of crucial importance. And you ended up having a dual primary endpoint, which I think sometimes is very difficult for having an RCT with a dual primary endpoint of having the weight loss and the quality of life as a kind of a composite endpoint. And perhaps if you would like to comment on that. And also, as we now know that percent excess weight loss is actually not the preferred standard. So it's great that you have the percent total weight loss data, but looking, for example, at the sleeve pass and the SMBOSS RCTs that already have a 10-year follow-up data, there is a clear difference in the percent total weight loss already in those trials favoring bypass. So that's something we actually already know. And the problem with the categorical variable having percent excess weight loss over 50% or under, that means that 51 is good, 49 is bad, and that's always a problem when using a categorical variable, which we actually now try to get rid of in the IFSO consensus, that we would actually take into consideration more than just categorical variables. So a very quick comment on the primary endpoint, and then we will go on further for the longer term results. And we have very many questions in the Q&A box also for reflux, but maybe first for the primary endpoint, Jane.
So when we designed the trial, it's out of date now, but that was why we chose that binary endpoint. But I think one of the important things about our co-primary is it does give the quality of life there, and that's what the patients wanted. And I think it's been a bit of extra hard work getting that data, but having both is actually valuable. And in terms of the health economic analysis, it's critical in the UK. So I think having them both there, being clear about your hypotheses for both is fine, provided you pre-select it all and are very clear about it. Because we've got TWL as a secondary endpoint, I'm not worried. We can easily do meta-analyses across the trials with our secondary endpoint. So it's still easy to calculate that and share the data.
Yeah, more it's also for the statistical power analysis that sometimes it's tricky to have more than one primary endpoint, but maybe we go to our panelists. So first impressions from Torsten and then Moritz.
Hello, everybody. Thank you for having me in this very nice session and very important session, I think, because it's a scientific achievement that we are looking at. Congratulations, Jane, to your enormous achievement and excellent presentation first, and all the achievement you have with a very important and excellent executed trial. And that's lying also in the design that you can actually answer the question that we all want to have. So I've been working in the field for 25 years, and quite frankly, I've been sometimes astonished and sometimes a little bit terrified by the big swings in the practices around the world. And you have been you have been looking into the field of bariatric surgery, as you say, as a scientist and as an upper GI surgeon. So I would just pick your head on what is your thoughts when you are looking into bariatric practice now for 15 years?
When I first looked at it, I was a bit horrified about how it was practiced and without the scientific evidence, if you like. And obviously I work across multiple surgical fields and I see that elsewhere, and I see it in plastic surgery, breast reconstruction as well. But what I think's been different about that, despite that, there are 12 centres in the UK that have decided to put that aside and to try to learn the whole process of randomisation and to try to build evidence-based practice. So, and of those 12 centres, there's 40 or 50 surgeons involved. So in many ways, I say in the UK that the bariatric surgeons are, head and shoulders above some of the other clinical teams who haven't yet embraced that. And there are other areas in the UK, but there are still plenty of surgical areas that haven't started working together, because it means having to collaborate, which is one of the challenges, as well as to put aside your preferences and biases. So I've been impressed. And also with yourselves, Paulina, and you both yourselves doing large-scale trials, it seems to me if there's a growing or slightly shifting scientific field to bariatric surgery, it's not just us in the UK, it's happening internationally, which is good.
Might it be that we have had a little bit of immaturity in the field about to mature as a specialty? Looking back, I can see that already in the 1990s, gastric bypass was the procedure of choice in open bariatric surgery. Then we had almost another field of surgery with the laparoscopic era. Learning things again, and then obviously sleeve gastrectomy came as a newcomer in the field. But I think it's important where you started, Jane, to say that when we communicate with our patients, we must separate between what we believe and what we know. And that is kind of the bottom line of your talk, and I just want to compliment that now we know something. Now we actually know when we randomize, because that's the beauty of the randomized trials, that it has no bias inbuilt in it. It's just between if you had a sleeve or you had a bypass. That's the difference. It's not about patient selection and everything. We have to appreciate that. That's the only way to take away the other things. So I might pass the torch to Moritz, and if we can go back.
Yes. Yeah, definitely. Thank you so much. And then we go to Moritz. I'm going to be interested to hear whether he starts with GERD or something else. We have a few questions on the GERD issue, but Moritz, first your initial comments, please.
Yeah, thank you, Jane, very much for this very interesting study and this great presentation. And also from the side of young IFSO, I think it's a very interesting topic for all the young surgeons all over the world. So this is really great for us. Two questions that I have here is, so you haven't really mentioned the way you're doing the different procedures, because I think all over the world we're doing different different types of gastric bypass. For example, the University of Vienna, and we are the largest center in Austria, we are doing our standard Roux-en-Y gastric bypass, for example, with an biliopancreatic lymph of 150 centimeter and only 70 centimeter alimentary lymph. But this is only an example. There are also some discussions about antral resection in sleeve gastrectomy and so on. And you have also included some different bariatric centers that have included their data in your study. So this is the first question. Do you think that this study is valid for other centers or for other centers all over the world or for other countries? Or do you think it's just an example for a study that can be true for different procedures or not?
Okay, so
Jane, before you answer, because there are actually three questions related to this in the Q&A, and please keep on sending your questions to the Q&A, because I think this is actually a very good question from Moritz, because your results are actually much poorer for the weight loss than they are for the other RCTs with longer term follow-up. So there actually, the few questions are that what is the technique for the sleeve gastrectomy? Could it be that there are some technical issues with the sleeve gastrectomy in your trial, based on the fact that it really is different from the other RCTs that have a longer term follow-up and better weight loss results? So
Yeah.
I think it's great that if you open up the surgical techniques a bit and maybe ponder on this question a bit. Thank you.
So I'm going to give you the principles of how we set the standards. So the way that we try to set surgical quality assurance in all surgical trials, because the absolute criticism over the history of time of surgical trials is surgeon who observes the trial says, if only they'd done it my way, the results would have been different. It's, if you look at the literature, any trial in area, surgeon just says, oh, if you'd done it my way. And so you have to think, how do you, and that's performance bias. You have to deal with how do you deal with performance bias in surgical trials to prevent that criticism. And the way we did it in Wideband sleeve is with a group of experts in our pilot phase, we set some minimal mandated criteria for each 3 procedures. I'm not going to go through them now because of time, but they had minimal mandated criteria. We prohibited certain things, and we had some things that was flexible between them. And you can then monitor those things, whether they were done. And when they were done out of protocol, I would go and talk to the centres, phone them up, email them, and so on. But they were flexible within those minimum mandated criteria. Now, not in Wideband sleeve, but in other trials we've done, we've also videoed the surgery, because what surgeons say they do is sometimes different to what they actually do. But the key is you set those standards. Now, I would argue one of the reasons, and surgeons are obsessed by this, understandably, because we buy into what we do, and you feel so personally responsible for your surgical outcomes. But I would say possibly one of the reasons why we have different results to the other trials with long-term data is not because of lack of performance bias, but in those other trials, there's less rigorous trial conduct. And there's the bias in those other ways, maybe how randomization was performed, maybe how follow-up was done, those sort of other aspects of a trial design, which may have biased their other findings. So you need to sort of look across all of it, not just at one aspect of bias. You need to look at all the different components of bias in a trial in the process of it trying to believe the results. But in Wideband sleeve, we set these standards, and all the sleeve surgeons were the same as the bypass surgeons. All the centres had to meet minimum criteria before they took part, and they all enter their data into our national registry. And I mean, I'm not being a bariatric surgeon, I wasn't aware of any of them being deficient, but Richard and Jim, who were very much involved in this trial and the running of it, we were very careful about which surgeons were participating. So, but we will detail that in our papers in much more detail, because it is the question I've been asked again and again.
I think that's very interesting, because of course all the other trials aim to do the standardization also, and everybody was doing sleeves and bypasses. So really, I think that may be the key question, that it really is a bit different from the other RCTs, even though we have the same aim for standardization. But Moritz, you had another question?
Yes, I had another question, and then I saw that Thorsten has a comment. But maybe my second question is, yeah, of course, Pauline, you know me, and I want to talk about the reflux after sleeve gastrectomy. And
hey, I'm with you.
We know from short-term studies, and I think 3 years is up to short-term, that reflux is not really a huge topic in sleeve gastrectomy, but it's gaining more and more in the long-term outcome. But I saw that your main quality of life score for reflux was the gastrointestinal quality of life score, right? But I think this score, I think it has 48 questions, and it's focusing on different types of gastrointestinal issues, starting from flatulence, abdominal pain, and reflux is only a small part of this questionnaire. So can you maybe comment on that? Do you have maybe something more specific for reflux that the patients can report in?
No, you're absolutely right. there are about 5 questions on reflux in amongst the other questions in the Giggly Index, the gastrointestinal one. And we haven't in any other way measured reflux, but there are papers that have used the GI scale, the Giggly Index scale, and use more specific reflux scales and show good correlations between the two. So it may be useful. One thing we could do maybe is pick out just those 5 items from the scale and look at those as isolated items, because they are very reflux specific, but we haven't used any other measures.
Did you have a preoperative gastrointestinal endoscopy for the patients?
It was optional. Everything like that was optional. And
Yeah,
even
that's
even
too
if
bad.
you
Yeah.
if you imagine reflux was bad, it's not then impacting on other aspects of
Yeah.
quality of life. That's another thing worth thinking about. You know, the generic scores and the physical function and all those things are not showing, you know, that we're not seeing that there. But we could pick out the individual items and look in more depth at those.
Torsten, you had a comment on the reflux, because there's a question from Ronald Leem for the reflux, but go ahead, Torsten.
Yeah, I think I saw Ronald's comment, and it's about weighing what is kind of pros and cons, and this was a little bit of me thinking that about 10, 15 years ago, there was some kind of agreement that
I think you now have a bad connection, Torsten.
Do I have a bad connection? That's good.
Yeah, no.
I'm back. Sorry
Yeah.
about it. 10, 15 years ago, there was quite a good agreement about that Roux-en-Y was the gold standard. But then suddenly this shift happened, and I'm just stressing a little bit the community to think about: was this driven by the patient's real experience over a long time, or was it driven by who was the preference and who was the weighing done in this? I'm just thinking that we should be careful in when we had a procedure that obviously had problems. We can either think about what were the problems with the procedure making a group of patients accumulate, or we can shift to another procedure. And I think this is what we have seen and what we need to learn about for the last decade. It's a little bit about the throwing out the baby with the bathwater. If you think you have problems with some patients, do you shift the procedure for all patients in a way? That's a bit, and I'm just to finalize that. I think that we are now coming to the question that if you have said why not sleep, because the data were almost as good as the bypass. But in fairness, Paulina, not even in SMBOS and SleepPass were the outcomes as good with the sleep compared to bypass. So somehow we interpreted that why not? But
I fully understand what you mean. And Jane, I always tell when we talk about the SleepPass trial is that we had colleagues that are favoring sleep looking at the same trial, saying that, wow, now sleep is good. And the other ones are favoring bypass say, wow, now you showed this. And I said, you guys, you're looking at the same trial. So really, you have to really try to have an unbiased view. I think the main point is that you do have 2 good procedures, but even with our 10-year follow-up data of the RCT, I still don't always know what to recommend to patients, because sometimes it could be either or. But I think Ronald's question here is very valid. Of course, for the GERD, I don't think, Jane, for the 3-year results, you really can't say a lot, because at 10 years, it really is an issue. I think Barrett's is not going to be an issue, but I think GERD is really a major issue. So that's one thing you have to do for the patient selection. But what is going to be weighed in the decision making? And he has a specific question for you: that how would you suggest to extrapolate these trial results into the daily case mix? Not a very easy question, but as the randomized trials, of course, have very specific exclusion criteria. So if you have any comments for that, and I don't know if you have a comment or question, but go ahead, Jane.
Thank you. I think that our trial, our eligibility criteria were very broad. We showed that 68% of all patients in the UK coming through to bariatric surgery would have been eligible. So it is a deliberately really broad inclusion criteria with very few exclusions. So it is quite possible that they do apply to UK population for certain. But I think that It's a big question. And I think one of the things is not what we think and what we say to patients, but that we share the information with them. And then it becomes shared decision making, where you say to the patients, this is what we know now. 3 years down the line, these, we know about these three procedures, or the 2 important ones. And the patients that we've shared the data with so far, because it's all part of our trial to do everything with a patient advisory group, there have been several in that group who've had bypass band or sleeve, and there's been a unanimous response to the results. And the patients say, I'm delighted with what I've had. There was one lady, I thought I'd had the best procedure. Everyone told me I'd had sleeve. That was the best one. I was really pleased I was randomized to sleeve. I'm so shocked that I didn't have the best procedure. If I had my chance again, of course, I'd have the operation that led to the most weight loss and the best quality of life. So I think the key is not what we think we should do, but I would say share the results with the patients and let them make their minds up.
I think that's crucial, and of course, we have to give them the actual information as unbiased way as possible. Any comments from my colleague moderator Wai Yang?
Yeah, I would like to ask Jane several open questions about the study design. And in our country, we are running several RCTs as well. And we would like to know what's the biggest challenge you think in this study or in other RCT study, for example, the recruitment of patients or keep the high follow-up rate after the surgery. And the second question is how to manage RCT with 3 arms. Usually we only divide it into 2 groups. We already need several hundred cases, but if you increase to 3 groups, maybe we need 1,000 or 2,000 cases if we start some multi-center study. And the third question is why you still include banding in this RCT? As you know, in many countries we don't do any bands anymore, and some countries they just don't have any bands.
Yeah.
And so what's in my what do you think about it when you design your study at the very beginning? So maybe many PIs or surgeons want to know these questions.
Jane, for the sake of time, it would if you give a concise, a very good question, all of them, because it really is very hard to do this properly. So concise answer, so we have time for the poll. Thank you.
Yeah. So in terms of what's the most difficult, there's no one thing that's the most difficult. There's so many difficult things. You have to sort recruitment. You have to have retention in mind the whole way along. You have to be a good communicator, and you have to work in a team. I personally, being a surgeon, find that difficult. Relationships, recruitment, retention, they all begin with, you've got to be good at them. And I've made loads of mistakes along the way, and you need help with that. In terms of the 3 arms, I think 3, 4, 5 arm trials are what we need, and the numbers don't matter. We can overcome the recruitment numbers. We've got to aim high. We're doing multi-arm trials in the UK now, platform trials, which need loads of patients, and that's the future. And in terms of bands, we started it 12 years ago when we needed to answer that question. In 2015, we kept band in. You could criticize us for not dropping band at that stage when we introduced sleeve, but the answer was we wanted the definitive data. I think we have got the definitive data now, and I personally think in the UK we shouldn't be offering band on the NHS or privately. That decision will be made when the data get analysed by the policy makers.
There are very many interesting questions in the Q&A. We are unfortunately not able to go into detail for revisional surgeries after recurrent weight gain after sleeve, or all of the other interesting topics, including the choice of procedure in patients thinking about pregnancy. But we will aim to answer the questions, so you will have it with the recording. So we will have written answers associated with the webinar recording. So we will provide these answers for you for your questions as we are out of time for answering them all online. So thank you very much for your activeness. But now, after seeing the data, we would like to do the poll again. So will the poll be different now when you've seen the data and you know the other long-term data of the other RCTs? What will happen? How will the available long-term RCT data on sleeve versus bypass will influence the rates of sleeve gastrectomy within the next 5 to 10 years? So again, exactly the same choices. Last time it was number 3, but then we have the first. So please vote. And Stephanie, when you think you have enough votes regarding the number of participants, as I unfortunately don't see the number of voters, so please just show us the votes when you have enough. It will be really interesting to see whether we've changed, because I think we all share the same idea that we want to have evidence-based surgical practice. But it really rarely is black and white. So it really is not just one outcome assessment. It is joint decision making, taking into account very many parameters. So again, you see, we did, the ones that were more skeptical did increase a bit, but still reduced interest, but still commonly used, clearly wipes the table clean. So that is the definite opinion on the participants, and I think maybe also for the discussion and kind of weighing in all of the issues. But it's really great that we now have more randomized controlled trials that we have the data on, and I really thank very much Professor Blaseby for the excellent presentation and completing the very arduous trial, and our distinguished panelist and my colleague moderator. So it has been a very interesting Ifso-Ec and Young Ifso joint webinar. Thank you very much for attending, and this recording will be available in the website, and hopefully, Jane, we will get some answers for the Q&A to attach to the recording. Any final comments? Thank you very much, everybody, for participating. Thank you very much.
So,
Thank you very much.
thank you.
Bye.
Bye.